So in this module, we'll be talking about the other benign conditions of the esophagus, including the motility disorders, which includes achalasia, which is a very, very important topic, not only for your college exams, but also for the entrance exams. So the first topic which we're going to talk about are esophageal diverticulae. Now, esophageal diverticulae can be of three types. You can have diverticulae in the upper one-third, you can have diverticulae in the upper one-third, you can have diverticulae in the middle one-third, and you can have diverticulae in the lower one-third. And there can be diverticulae in the lower one-third. The upper one-third diverticula is known as Zenker's diverticula, which I'll talk about in detail. But here I just want you to know that it's a false diverticulum. It's a false diverticulum. False means it only has the mucosa. It only has the mucosa. Middle one-third diverticulum is known as parabronchial diverticulum. This is known as parabronchial diverticulum, and in 2 exams this has been asked that this parabronchial diverticulum is the only true diverticulum of the esophagus. It is the only true diverticulum of the esophagus. This you need to know about. This has been asked in the exam. It is the only true diverticulum, and by that I mean that it has all the layers. All the layers are going to out pocket or out pouch into a diverticulum. Now this parabronchial diverticulum is seen in 2 conditions. It is seen in tuberculosis and it is seen in histoplasmosis. And what is the cause of this? This is an example of a traction diverticulum. This is an example of a traction diverticulum. Now, what exactly do we mean by a traction diverticulum? So what I mean is that because of these tubercular lymph nodes, so you have lymph nodes in the thoracic cavity, you have these lymph nodes with tuberculosis, and you know tubercular lymph nodes will also have an inflamed capsule. There is periadenitis, and because of this periadenitis, they are very sticky. So these lymph nodes become stuck to the esophagus. They become stuck to the esophagus. And as the disease heals, with fibrosis, it pulls out the esophagus. As the disease heals, it pulls out the esophagus, thereby leading to a diverticulum. So it's a traction diverticulum which pulls out all the layers, and the diagnosis can be made by a barium. Solo. And the management of this patient, if it is a symptomatic diverticulum, which is more than 2 centimeters, then we need to carry out excision. Otherwise, we need to treat we just need to treat the primary condition. That is TB or histoplasmosis, and it will take care of it. Only if it's a symptomatic diverticulum which is more than 2 centimeters in size, then only we need to excise it. So this you need to know is the only true diverticulum. Lower one-third, you have the epiphrenic diverticulum. And this epiphrenic diverticulum is also a false diverticulum. And this is a pulsion diverticulum. Pulsion means which comes out due to increased pressure. And it is the same as Zenker's. Zenker's also is a pulsion diverticulum. That means it comes out because of increased pressure. Now this epiphrenic diverticulum is more common on the right side. Again, diagnosis can be made by a barium. And the management of these patients, if it is a symptomatic diverticulum, which is more than 2 centimeters, then we carry out excision. Otherwise, just observation is required in these diverticulae. Now, Zenker's diverticulum is a very important topic. Zenker's diverticulum, another name mentioned in the latest Sibiston is cricopharyngeal achalasia. So that's another name for Zenker's diverticulum. It is called cricopharyngeal achalasia. And this occurs through the Killian's dehiscence, which I've told you is a potential space between the thyropharyngeus and the cricopharyngeus. You know the thyropharyngeus has oblique muscle fibers and the cricopharyngeus has transverse muscle fibers, and there is a potential space between these two which is known as the Killian's dehiscence. So this is your thyropharyngeus and this is the cricopharyngeus, which are the 2 portions of the inferior constrictor muscle. And this diverticulum comes out due to increased pressure. And why does increased pressure occur? Increased pressure occurs because of incoordinated or discoordinated muscle contraction. So because of discoordinated muscle contraction, there is increased pressure which is generated, and that's when the mucosa outpouches and it is a false diverticulum. Now, another question which has been asked in the exam is that it usually starts in the midline posteriorly, but the final position is left of midline. The final position is left of midline. And because it starts posteriorly, that is why I'll tell you later on that when we do a barium swallow in these patients, we should always do a lateral film as well to see whether it is posterior or not. Okay, so this you should know that it starts in the midline posteriorly and the final position is left of midline. Now, the clinical features of Zenker's diverticulum, this is commonly seen in the 4th to 6th decade of life. It is commonly seen in the 4th to 6th decade of life. And in this diverticulum, what happens is that this is the diverticulum which is there. So whatever the patient is eating, some of it is going into the diverticulum and some of it is going down into the esophagus. Now, this food which is collected in the diverticulum, when the patient lies down, this food will all come into the mouth. So that is called regurgitation. So the most common presenting feature, the most common presenting symptom of Zenker's diverticulum is regurgitation. Food is going to come back into the mouth. This is called regurgitation. And this food is just getting stale there. It is lying there. So it is going to produce a bad odor. So that is known as halitosis. Halitosis is a bad odor which comes out bad. Mouth odor is halitosis. Also, this diverticulum later on can give rise to dysphagia. This dysphagia is of course intermittent dysphagia. It will be more when the diverticulum is full. It is intermittent dysphagia. Now, there can be certain complications as well. The complications are that when the patient lies down, supposing the patient is sleeping at night and all the food comes into his mouth, right? So while sleeping, the patient can aspirate this food. So the most common complication is aspiration pneumonitis. This has been asked in the exam. The most common complication is aspiration pneumonitis. That is the most common complication. And lung abscess formation can also be seen in these patients. Lung abscess formation can also be seen in these patients. So to confirm the diagnosis, the investigation of choice is a barium swallow. It is a barium swallow. And when we do the barium swallow, you can see the Zenker's diverticulum here. You can see the Zenker's diverticulum in this barium swallow. Now, the management of these patients with Zenker's diverticulum, if it is a symptomatic diverticulum, then we need to carry out surgery. And if the diverticulum is more than 2 centimeters in size, then the two options which we have are we can either do a diverticulectomy. We can do a diverticulectomy plus a cricopharyngeal myotomy. So diverticulectomy means we are cutting the diverticulum. And cricopharyngeal myotomy means we are cutting the muscle. Now you might ask that why are we cutting the muscle? So the reason of cutting the muscle is so that a recurrence does not occur, right? Because if you don't cut the muscle, then again discoordinated muscle contraction will happen and again the outpouching will happen, right? So that is why cricopharyngeal myotomy reduces the recurrence. Another option available in these patients is called endoscopic diverticulopexy. Endoscopic diverticulopexy with cricopharyngeal myotomy. So what do we do in endoscopic diverticulopexy? So diverticulopexy basically means that supposing this is the diverticulum, now what is happening that the food is going, substantial portion of the food is going into this diverticulum. Pexy means supposing this is the mouth of the diverticulum, I'm going to open up the mouth of the diverticulum, right? I'm going to open up the mouth of the diverticulum. And if I open up the mouth of the diverticulum, what is the final orientation which I'm going to get. So the final orientation which I get is somewhat like this. So the advantage of this is that food will not stagnate, food will come down. Now, how do we carry out this diverticulopexy? The classical approach, and this was asked in the NEET exam 3 years back, the classical approach for this diverticulectomy is to use a stapler. That is the classical approach. But lasers are also being used. Lasers are being used now, but the classical approach is using a stapler, a linear stapler. Okay. So these were the surgical procedures which can be done for Zenker's diverticulum. You should also know that if it's a very small Zenker's diverticulum, botulinum toxin, Botox, can be used, but again it has a high recurrence rate. Botox has a high recurrence rate. And you should know that Zenker's can increase the risk of squamous cell carcinoma of the esophagus. I told you that Zenker's can increase the risk of squamous cell carcinoma of the esophagus as well. So this was regarding Zenker's diverticulum, which is a very important short note for your college exams, and lots of MCQs are also asked from it. So I've already told you about the other diverticulum, the parabronchial diverticulum and the epiphrenic diverticulum. I've already told you the points which you need to know. Moving on to hiatal hernia. So hiatal hernias, there are two statements which I want you to know before I tell you about hiatal hernias, because these statements have been frequently asked in the exam and students commonly get confused between the two. So the first statement is, what is the most common diaphragmatic hernia? And when I ask this question in my class, majority of the students answer a congenital diaphragmatic hernia, that is Bochdelic hernia. But that is not the answer. That is the wrong answer. The correct answer is sliding hiatal hernia. So the most common diaphragmatic hernia is a sliding hiatal hernia, whereas the most common congenital diaphragmatic hernia, is known as Bochdelic hernia, and this is left posterolateral. Right? So it is Bochdelic hernia, which is left posterolateral, which is the most common congenital diaphragmatic hernia. But most common diaphragmatic hernia is a sliding hiatal hernia. So there should not be any confusion regarding these two statements. Now we've already covered the normal anatomy of the hiatus and the lower esophageal sphincter. What we discussed was, this is the esophagus, and this is the diaphragmatic opening, and normally the GE junction is intra-abdominal. So this is normal. This is the normal anatomy of the hiatus, right? Now, what are the types of hiatal hernia? So type 1 hiatal hernia is known as sliding hiatal hernia. Type 1 is known as sliding hiatal hernia. And this sliding hiatal hernia is the most common type of hiatal hernia, which I've just told you. It is the most common type of hernia. In fact, there in books it is written that if asymptomatic patients, if you do a barium in these patients, approximately 15 to 20% will have asymptomatic sliding hiatal hernias, right? So that's how common it is. Now, in sliding hiatal hernia, what happens is, that the gastroesophageal junction migrates proximally. The GE junction, it migrates proximally, okay? So this was our diaphragmatic opening. Now the GE junction is lying in the thoracic cavity. So it migrates proximally. And because it migrates proximally, we discussed that the length of the intra-abdominal esophagus will reduce. And because it goes into the thoracic cavity, what will it predispose to? It predisposes to GERD, right? It predisposes to gastroesophageal reflux disease. So that is how patients will present. Patients are going to present with features of GERD only. Which is why, remember, I told you one of the indications for surgery in GERD was that if a patient has symptoms and a large hiatal hernia, that is also an indication to carry out surgery. Now, how do we confirm the diagnosis? So the investigation of choice according to the latest Bailey, and that's what we'll follow, is CT with oral contrast. Is CT with oral contrast. This has also been asked in the exam. This is what is written in Bailey. It is CT with oral contrast. Of course, we can even do a barium. We can even do a barium meal in these patients, and we can see the hiatal hernia. Now you can see here, if you do an X-ray, on the simple X-ray also, you can see that this was a very large hiatal hernia where you can see the G junction has migrated proximally. So it can appear as a separate shadow in the chest X-ray as well. It can appear as a separate shadow in the chest X-ray as well. A sliding hiatal hernia on barium, I told you, this is the G junction which is migrated proximally, and the patient presents with features of GERD. Now, the management of these patients, the management of patients with sliding hiatal hernia, if it's a small asymptomatic hernia, then we will just do observation. Then we just carry out observation. Nothing is to be done. But if it's a large and symptomatic hernia, then we have to carry out surgery. And what surgery will we do in these patients? The surgery is going to be fundoplication, because fundoplication, we are going to restore adequate length of the intra-abdominal esophagus, and we'll bring down the GE junction. We're going to bring down the GE junction intra-abdominally. So fundoplication, what I discussed in the first module, that is what we'll carry out if it's a large and symptomatic. Otherwise, we don't do surgery for sliding hiatal hernias. Also, I want you to remember that sliding hiatal hernias are not life-threatening. They are not life-threatening. All they can give rise to is GERD, right? So they are not life-threatening. The other types of hernias, the next type of hernia is a rolling hiatal hernia. The next type is a rolling hiatal hernia. So rolling or type 2 or paraesophageal hernia is when a portion of the stomach migrates into the thoracic cavity through the hiatal opening, right? And the gastroesophageal junction is usually normal. And this portion which is migrated can undergo volvulus and necrosis, and this can be life-threatening. So what happens here in type 2 is, what happens that this is the esophagus. A small portion of stomach herniates through. The G junction is usually intra-abdominal, and this is the portion of the stomach which has gone into the thoracic cavity. And this portion of the stomach which has gone into the thoracic cavity can undergo volvulus and necrosis, and that is why this can be life-threatening. That is why type 2 hernias can be life-threatening. Also, when this herniation happens, there can be longitudinal ulcers at the base. There can be longitudinal ulcers which can occur at the base of the herniation, and these ulcers are known as Cameron's ulcers. This has also been asked in the JIPMER exam. These ulcers are known as Cameron's ulcers, which are at the base of this herniated portion. Now, rolling hiatal hernia patients. So I told you what will be the clinical features of rolling hiatal hernia patients. These patients can come with chest pain. There can be chest pain. If there is necrosis or volvulus, it will be an emergency. If there is necrosis or volvulus, it will be an emergency. And GERD can occur, but it is rare. It is not as common as in sliding hiatal hernias. Okay. Again, when you do a barium in these patients, so you can see in the barium that the stomach has herniated. A portion of the stomach has herniated through the hiatus, and this can undergo volvulus and necrosis. So the management of rolling hiatal hernias, all rolling hiatal hernias require surgery. And why do all rolling hiatal hernias require surgery? Because this condition can be life-threatening, because there can be volvulus or necrosis, right? So that is the main difference between sliding and management of rolling hiatal hernia. Type 3 is called mixed hiatal hernia, where there is both a sliding component and a rolling component. So a common sense question, if there's a both sliding and a rolling component, which component will determine the treatment? Obviously, it will be the rolling component which determines the treatment, because the rolling component can be life-threatening. And type 4 has also been mentioned. It is a paraesophageal hernia, but the content is not stomach. It is some other structure other than the stomach. So when another structure other than the stomach herniates through, that is called type 4 paraesophageal or type 4 hiatal hernias. So moving on to the next topic. The next topic is esophageal perforations. Now, esophageal perforations can be of two types. You can either have iatrogenic perforations. There can either be iatrogenic perforations which occur post-endoscopy, or there can be spontaneous esophageal perforations which are known as Boerhaave syndrome. So I'm going to talk about both of them. First, we'll talk about iatrogenic esophageal perforations. So iatrogenic esophageal perforations are most common, right? So these are the most common perforations. And where will they occur? Remember the surgical anatomy part? The upper 1/3, the pharyngoesophageal junction, that is the narrowest portion of the GIT. So it commonly occurs in the upper 1/3, close to the pharyngoesophageal junction. And what are the scenarios when there is an increased risk of perforation? So this has been mentioned in both Bailey and Sebastian, that when we are doing a therapeutic endoscopy or we are doing an endoscopy in cancer, those are the situations where a perforation might occur. How will the patient present? The patient presents with chest pain or abdominal pain post endoscopy. That is how the patient is going to present. That is how the patient will come to us. So if the patient is complaining of chest pain or abdominal pain post endoscopy, to confirm the diagnosis, the investigation of choice is a CECT. That is how we can confirm the diagnosis in a stable patient. And if it's an unstable patient where the hemodynamic status is unstable, there of course we will not do a CT. There we can do a contrast study. And the contrast study is iohexol, we've already discussed, is better than dinosil. Iohexol is better than dinosil. So that's how we can confirm the diagnosis. The management of iatrogenic perforations. The management is going to be, if it's a small perforation, if the perforation is usually in the cervical region, if it's in the cervical esophagus, and if the patient is stable, then we will do conservative management. Okay, conservative management would entail that we'll make the patient NPO. What is NPO? We make the patient nil per oral. Give nothing by the mouth, give bowel rest. Nothing by mouth, give bowel rest. We are going to give IV fluids in these patients. IV antibiotics will be given in these patients. IV fluids, IV antibiotics, painkillers will be given. And we just observe these patients. The perforation would heal on its own. If it's a large perforation, if it's in the thoracic esophagus, or the patient is unstable, then in these situations we have to carry out surgery. And what will be the surgery which we'll do? We'll carry out a thoracotomy because we want to expose the esophagus. So we carry out a thoracotomy, plus we repair the esophagus, and once we've repaired the esophagus, we're going to put in a chest tube, plus insertion of a chest tube. So iatrogenic perforations have a better prognosis than spontaneous perforations. I'll tell you, spontaneous perforations have a very high mortality rate. So this is how we manage patients with iatrogenic esophageal perforations. Now, spontaneous esophageal perforation is known as Boerhaave syndrome. This occurs when there's forceful vomiting against a closed glottis. And this is commonly seen in alcoholic patients, right? This is commonly seen in alcoholic patients. And when there is forceful vomiting against a closed glottis, the lower 1/3 of the esophagus can perforate. And what is the most common site where this perforation occurs? This has also been asked. It is the left posterolateral wall of the lower 1/3. So this is very important. It is the left posterolateral wall of the lower 1/3 of the esophagus. Now, before I talk about the clinical features and the management, one thing which I want to tell you here is please don't get confused between Boerhaave and Mallory-Weiss tear. Okay? Boerhaave and Mallory-Weiss are very different things. The reason why students get confused in a clinical question is because both occur in alcoholics and both occur after vomiting. But in Mallory-Weiss tear, what is going to happen? So Mallory-Weiss is just a tear in the mucosa and the submucosa. Is just a tear in the mucosa or the submucosa. Whereas Boerhaave syndrome is a full thickness perforation. I mean, all the layers will get, it is a perforation. So that is difference number one. And difference number two is Mallory-Weiss tear is going to come with upper GI hemorrhage. Patient will come with hematemesis or upper GI hemorrhage. Boerhaave syndrome, the patient comes with chest pain or the patient comes with Mackler's triad. Mackler's triad. I'll tell you what Mackler's triad is. And in Mallory-Weiss tear, it's majority of the times it is self-limiting. It stops on its own. Whereas Boerhaave syndrome, patients will definitely require a surgery and there is a high mortality rate. So don't get confused. In the question stem, look for keywords. If you are given a question stem, I don't want any confusion between Mallory-Weiss and Boerhaave syndrome. So the patients usually come with Mackler's triad, and Mackler's triad has been asked in the exam. This is chest pain, retching, and subcutaneous emphysema. So the patient feels like vomiting, there's retching, chest pain, subcutaneous emphysema. That is how the patient presents. There can be fever as well. Patient can present in sepsis also. One of the signs which we get here is a Hammond's crunch. And Hammond's crunch occurs because there is pneumomediastinum. So when the esophagus ruptures, when the esophagus perforates, air comes into the mediastinal space. Air is going to come in the mediastinal space. And that gives rise to pneumomediastinum. So when there is pneumomediastinum and you auscultate the heart, you will get a crunching sound. And that is known as Hammond's crunch. And this crunching sound has been described as if you're walking on snow. So if you walk on snow, every step you take, there is a slight crunch which comes. And that's the same sound which you auscultate when you're auscultating the heart of a patient with Boerhaave syndrome. So that is known as Hammond's crunch. Again, the investigation of choice here, if it's an unstable patient, so most of the time these patients are unstable only, it is a contrast study. And again, I'm repeating so that it gets ingrained, that contrast study, iohexol is better than dinosil. And if it's a stable patient, then we can do a CECT, a contrast enhanced CT scan can be done. Now, when we do an X-ray in these patients, if you do an X-ray in these patients, you can get pneumomediastinum. Which I told you is air in the mediastinal space. And there are certain signs of pneumomediastinum which Dr. Mayur has beautifully covered. So you can refer to his modules for the details regarding those signs. But the signs are Spinnaker sign, ginkgo leaf sign, and the continuous diaphragm sign. So these are the signs which you can see in pneumomediastinum in a patient with Boerhaave syndrome. You can also see a left-sided pleural effusion because the perforation commonly occurs on the left side. So that is why a left-sided pleural effusion can also be seen in these patients. You can see here that this is a contrast study, and you can see that the contrast has extravasated into the mediastinal space. And in the CT also you can see that there is gas. All is gas around the esophagus. You can see the gas around the esophagus. You can see here, so there is a pneumomediastinum which has developed. Now, how do we manage these patients with Boerhaave syndrome? So in Bailey, it is written that if these patients present early means within 12 hours. So if these patients present within 12 hours, which is very unlikely, mostly these patients come late only. So if these patients come early within 12 hours and there is minimal sepsis, and there's a stable patient. So in these patients, we are going to take up these patients for a thoracotomy. And we will repair the tear. Plus we put in a chest tube. As well. Now, one thing which I want to highlight here, if it's a small perforation, like in iatrogenic perforations, if we were doing surgery, or if a Boerhaave patient presents early, there is one thing which is written in Sebastian, and of course it's not being done very frequently, it's still in its nascency, and that is endoscopic vacuum therapy. Right, so what exactly, this is a latest treatment. So remember the vacuum assisted closure which I've discussed in plastic surgery, where we use negative pressure or vacuum to hasten the healing, right, where minus 120 millimeters of mercury is used to hasten the healing. Similarly, a vacuum therapy can be done to heal perforations, to heal esophageal perforations, but this is only done in patients where there is iatrogenic perforations, or if the patient comes early and there is minimal sepsis, in Boerhaave's, which is very unlikely. Most of the times these patients come late only. So I just want you to remember the term endoscopic vacuum therapy, which is being used for esophageal perforations. Now, majority of the times these patients are going to come late, and there is increased sepsis, and these patients are unstable. Okay. So in these patients, you of course resuscitate the patients and you have to take them up for emergency surgery. You have to take them up for an emergency thoracotomy. Right. Now, your anesthetist here will tell you, look, that the patient is unstable. You can't operate for very long. You need to finish the surgery quickly. Otherwise, the patient will die. So in these patients, how do we finish the surgery quickly? What is the quick fix which we do here? And I want you to know a dictum, and that's how you'll understand this quick fix, because when I tell you the quick fix, you'll think it's such an odd surgery to perform. But you should always know, in trauma surgery, always remember that a living problem is better than a dead solution. Right? So in emergency surgery, a living problem is better than a dead solution. You can always deal with the problem later on. So what we do here is that this is the esophagus and this is the stomach. This is the esophagus, this is the stomach, and this is the large perforation which is here. So what we do is we put a stapler here, we cut out the perforation. The proximal end of the esophagus. The proximal end of the esophagus is taken out in the neck as an esophagostomy. Right? So all the secretions are going to come out through this opening. All the saliva will come out through this opening in the neck. The distal end we close. We close the distal end, and for nutrition we carry out a gastrostomy. Okay. Now, this is the quick fix surgery. After 10 to 12 weeks, if the patient is fine after 10 to 12 weeks, we can anastomose the two ends. So that is the surgery which is done if the patient presents late. Well, up till now in my career, when I was a postgraduate and SR, there's just one case of Boerhaave syndrome which I have seen, and I was a final year postgraduate then, and my senior resident was the one who performed the surgery. This is the surgery which we performed. Unfortunately, the patient had come very late and he succumbed to the disease after 5 days. But there's just once that I've seen an esophagostomy being taken out in the neck. So that is the management of Boerhaave syndrome. In Boerhaave syndrome, you should know about Mackler's triad, Hammond's crunch, and you should know how do we make the diagnosis and treat the patient. The next benign condition which we need to talk about is a Schatzki's ring. Now this Schatzki's ring is most commonly a mucosal. Mucosal is most common, but sometimes it can be a submucosal ring. Sometimes it can be a submucosal ring, which is usually situated in the lower 1/3 of the esophagus. It is in the lower 1/3 of the esophagus. And this ring, so all these webs and rings give rise to intermittent dysphagia. Right? They don't give rise to progressive dysphagia, they give rise to intermittent dysphagia. And how do we get to know? The investigation of choice is a barium. So barium is what we do, and that is how we get to know about this Schatzki's ring. So you can see here that this is the Schatzki's ring which is developed, which we can see on a barium. The management of these patients, how do we manage these patients? So management, only symptomatic patients, only when there it is a symptomatic patient, then we carry out balloon dilatation. We carry out balloon dilatation in these patients. Only in symptomatic patients we carry out balloon dilatation. Otherwise, asymptomatic patients, just observation is done. Another thing which I want you to know, on barium, the Schatzki's ring is known as a B ring. Now, what are these ABC rings which we can see in the esophagus? You should know this. A ring. This is the A ring. A ring is a muscular ring. A ring is the muscular ring, and this is the proximal end of the vestibule. This is the proximal end of the vestibule. Right? The B ring is a mucosal ring, also known as a Schatzki's ring. And sometimes you will get a C ring as well. Sometimes you will get a C ring as well. And the C ring is the distal end of the hiatal hernia. It is the distal end of the hiatal hernia, sliding hiatal hernia if it is present. So the most popular one is the B ring, which is the Schatzki's ring, which I've just told you about. Another condition from which a couple of questions have been asked in the last 4-5 years is feline esophagus. Now, feline esophagus is when you get these lines on the esophagus, which you can see on barium, and they resemble the markings on a cat or a tiger. So, before I show you the barium, let me just tell you the conditions in which we can see feline esophagus. So, the conditions in which we can see feline esophagus are GERD, gastroesophageal reflux disease, and we can see it in eosinophilic esophagitis and in eosinophilic esophagitis in children. Now, GERD is a much more common cause of feline esophagus than eosinophilic esophagitis, and this question has been asked in the exam. In GERD, the feline esophagus is seen in the lower 1/3. It is seen in the lower 1/3, whereas in eosinophilic esophagitis, which is an idiopathic condition, commonly seen in children, this eosinophilic esophagitis is seen in the upper 1/3 or the proximal 1/3 of the esophagus. Now, the diagnosis is confirmed by a barium, and when we do a barium, you will see these linings in the esophagus, right? These linings in the esophagus, and they resemble the linings on a tiger or a cat. Now, this is one of my favorite pictures, and I have it enlarged at my home. This I clicked in a safari during Ranthambore, and this tiger's name was Arrowhead. And this tiger's name was Arrowhead because of the markings on the forehead were like an arrow. And, you know, I was very lucky. Just last year, again, I went to Ranthambore, and I sighted Arrowhead's daughters as well. Right, so I just wanted to share this picture. The linings are similar to what we see in feline esophagus. If we do an endoscopy, you will get a stacked up appearance. You get a stacked up appearance of rings. A stacked up appearance of rings is seen in feline esophagus. Of course, the management is dependent on the primary disorder. Another update in the latest Baileys regarding esophageal infections. And 3 years back, I remember in the NEET exam, in one NEET exam, there were 2 questions from esophageal infections. So you should know the basics of these esophageal infections as well. Esophageal candidiasis is the first one. Esophageal candidiasis is usually associated with oral thrush or oral candidiasis, and it is seen in immunocompromised patients. On endoscopy, you will see shaggy deposits in the esophagus, and barium swallow will show shaggy appearance and worm-like ulcers. Shaggy appearance and worm-like ulcers, they have been described as being similar to varices. So worm-like ulcers similar to varices. So this is what you can see here. You get this shaggy appearance or worm-like ulcers in esophageal candidiasis. The other esophageal infections are cytomegalovirus. Cytomegalovirus CMV is seen in post-transplant patients and commonly with GVHD. GVHD is graft versus host disease. And the appearance is very important. This was asked in the exam. You get serpiginous or geographical ulcers. So you get serpiginous or geographical ulcers in cytomegalovirus, right? In cytomegalovirus. Herpes infection is associated with herpes labialis, and you will get small ulcers with raised margins. In herpes infection. So these were the esophageal infections which you need to know. So let's now talk about the motility disorders of the esophagus. And in the motility disorders, you need to know that the investigation of choice for motility disorders is manometry. Now, this manometry can either be conventional manometry or it can be high resolution manometry. So, conventional manometry or it can be high resolution manometry. Now, the latest classification for motility disorders is known as the Chicago 3.0 classification. And the Chicago 3.0 classification utilizes high resolution manometry. So what exactly is the difference between high resolution manometry and conventional manometry? In conventional manometry, the sensors are kept 3 to 5 centimeters away. Whereas in high resolution manometry, the sensors are kept 1 centimeter apart. So you get a better representation of the manometric findings in high resolution manometry. So like I told you, in high resolution manometry, the sensors are 1 centimeter apart, and in total we have 36 sensors which measure the manometric pressures. In conventional manometry, they are 3 to 5 centimeters apart. The old Chicago classification used to measure the values in millimeters of mercury, whereas if you look at the latest Chicago 3.0 classification, which we'll talk about in detail, here the DCI, IRP are measured, right? So what are these terms? These terms which are used in Chicago 3.0 classification, let me first explain these terms to you so that when we talk about the motility disorders, the understanding is better. So there are 3 metrics which are used in the Chicago 3.0 classification. You have IRP. IRP is integrated relaxation pressure. Right? And this tells us the mean of the 4 second of maximum swallow-induced lower esophageal sphincter relaxation. Right? So basically what it tells us is that if there is an elevated IRP, if there is an elevated integrated relaxation pressure above normal, that defines that lower esophageal sphincter relaxation is not occurring. So if the integrated relaxation pressure is higher, then the lower esophageal sphincter is not relaxing. And in which condition doesn't it relax? In achalasia cardia. Right? So it doesn't relax in achalasia cardia. The DCI is the distal contractile index. This tells us the amplitude of contraction into the duration, into the length of the esophageal contraction, right? Of the esophageal contraction. So it measures the strength of the distal esophageal contraction. And distal latency is the interval between the upper esophageal sphincter relaxation and the peristaltic contractile deceleration, less than 3 centimeters proximal to the lower esophageal sphincter. right? So how quickly is the peristalsis traveling? How quickly is the peristalsis traveling? That is the distal latency. And decreased distal latency is an indicator of spastic achalasia. That means type 3 achalasia. So these were three terms which are used, and again we are going to put them to use when we talk about individual motility disorders and the Chicago classification in detail. Now, the first motility disorder which I want to talk about, this is not the most common one, but majority of the questions are asked from achalasia cardia only. And achalasia cardia literally means failure to relax. So there is failure of the lower esophageal sphincter to relax in this condition. And this occurs because of loss of ganglion cells in the myenteric and the Auerbach's plexus. And this is usually seen in the lower half of the esophagus. Now, these ganglion cells are derived from the neural crest. This has also been asked in the exam. And these ganglion cells are inhibitory ganglion cells. They are inhibitory ganglion cells. That means when these inhibitory ganglion cells fire, they lead to relaxation of the lower esophageal sphincter. But if these ganglion cells are missing, then the lower esophageal sphincter will not relax, and that is what happens in achalasia cardia. Now, there are various types of achalasias which are there, and these have also been asked in the exam. Primary achalasia is when there is loss of ganglion cells. Secondary achalasia can be seen secondary to Chagas disease. This has also been asked in the exam. Chagas disease is seen in South America due to Trypanosoma cruzi infection. Vigorous achalasia is a rapidly progressive achalasia. Pseudoachalasia is seen in cancer. In cancer also you can have dilatation of the esophagus like you get in achalasia, and that is known as pseudoachalasia. And finally, you have AAA syndrome or Algrove syndrome. This includes 3 A's, that is alacrimia, achalasia, and ACTH-resistant adrenocortical insufficiency. ACTH-resistant adrenocortical insufficiency. So these are the various types of achalasias which you should know about. Now, how does a patient with achalasia present? What are the clinical features? So the clinical features of achalasia, the classical triad of achalasia, this has been asked in the exam, this you should know. The classical triad of achalasia is dysphagia, regurgitation, weight loss. So dysphagia, regurgitation, weight loss, and out of these, regurgitation is the earliest and the most common symptom. So remember, I told you in Zenker's also regurgitation was the earliest and the most common symptom. Here also in achalasia also regurgitation, that means the food coming back into the mouth, is the most common and the earliest symptom. Dysphagia and achalasia is slightly different. It is initially to liquids more to solids, right? Liquids more than solids. And sometimes in the viva, the examiner asks, why is it more to liquids than to solids? So what happens is that solids have more weight. So because of the weight of the food, it tends to open up the lower esophageal sphincter. So in the initial phases, because of the solid food materials, the sphincter opens up. But because liquids have less weight, it does not open up. Of course, later on, it becomes more to solids than to liquids. Heartburn can occur. We've already discussed what heartburn is. Nocturnal coughing, right? Because of this regurgitation, there can be nocturnal coughing, postprandial choking can be there. And again, the most common complication, like in Zenker's diverticulum, is aspiration pneumonitis. Also, lung abscess formation can be seen, but the most common complication is aspiration pneumonitis. So these are the clinical features with which patients are going to present. Now, if you look at the investigations, the gold standard investigation to diagnose achalasia is manometry, right? And manometry, what are the manometric findings which are seen in achalasia? So in general, the manometric findings, you will find that there is ineffective contractions. In the body of the esophagus. ineffective contractions in body of esophagus, and there is inability of lower esophageal sphincter, to relax. The lower esophageal sphincter does not relax. So these are in general the manometric findings. But according to the Chicago 3.0 classification, there are 3 types of achalasias, and we need to know about the manometric findings in achalasia. And according to the Chicago 3.0 classification, there are 3 types of achalasias, and we need to know the manometric findings in them. So this is the Chicago 3.0 classification, and type 1 is the classical achalasia. Type 1 is classic achalasia, and in type 1 there is elevated integrated relaxation pressure. So we know if there is increased integrated relaxation pressure, that means the lower esophageal sphincter is not relaxing. That is what I told you. There is 100% failed peristalsis, so ineffective contractions are there. The DCI, the distal contractile index, is less than 100, and premature contractions are also there. Right? Premature contractions are also there. Type 2 achalasia is with esophageal compression, and here again the IRP is raised. IRP raised means again LES is not relaxing. Failed peristalsis is there, and there is pan-esophageal pressurization. And because there is pan-esophageal pressurization, that is why it is difficult to calculate the DCI. You will not get an accurate value of DCI in type 2 achalasia. In type 3, this is known as spastic achalasia. This was asked in the NEET exam. Spastic achalasia, again there is elevated IRP, means lower esophageal sphincter is not relaxing. There is no normal peristalsis, and there are premature spastic contractions with a DCI of more than 450. With a DCI of more than 450, those are the features seen in type 3 achalasia. So these are the 3 types of achalasias according to the manometric findings. Now, of course, in these patients, we also carry out a barium swallow. And when we do a barium swallow, what we get in achalasia, and this is a very important barium swallow, this is a bird's beak appearance. So as compared to cancer, where there was abrupt narrowing, here there is gradual narrowing. Here there is gradual narrowing, right? There is gradual tapering. So there is gradual tapering which is seen here. Gradual tapering is seen in achalasia, and also sometimes the esophagus can be massively distended. Sometimes the esophagus can be massively distended, and that is known as a mega esophagus. So you can have a mega esophagus as well, but there is gradual tapering, okay? And it is similar to this bird's beak. So this was a picture which I had clicked in South Africa, and this was a family of ostriches which was standing one behind the other, and I was very lucky to get this shot, and it was arranged height wise. So you could see the tallest one, then in middle, and then the shortest one. So you can see that there is gradual tapering in bird's beak appearance. There is gradual tapering as compared to abrupt narrowing which was seen in cancer. Now, once we've diagnosed this condition, how do we manage achalasia cardia? So the management of achalasia cardia can either be medical management, you can have medical management, you can have endoscopic management, or you can have surgical management, or there can be surgical management. So medical management is in the form of calcium channel blockers, CCBs, calcium channel blockers, and nitrates. This is not very useful. Not very useful in patients, calcium channel blockers and nitrates. Endoscopic management, you can have botulinum toxin, Botox or botulinum toxin can be used. And botulinum toxin is effective but has a very high recurrence rate. So this question has been asked in the exam. This has the highest recurrence rate in achalasia treatment. Because, you know, Botox is used for various conditions. You have seen these actors using Botox to straighten out their wrinkles. But the problem with Botox is that the effect only lasts for a few months. After a few months, again, wrinkles will appear. They again have to go for Botox sessions. So similarly, in achalasia also, they will require Botox again and again because it will definitely recur. The other endoscopic treatment is balloon dilatation, where we put in a balloon and we carry out balloon dilatation of the lower part of the esophagus and the lower esophageal sphincter. Now, balloon dilatation, the problem is that if you overinflate, it can give rise to esophageal rupture. If you overinflate, it can give rise to esophageal rupture in these patients. The surgical management of achalasia, the classical surgery which has been described for achalasia is lap Heller's myotomy. Lap Heller's myotomy, laparoscopic Heller's myotomy. That means we're going to cut the muscle. We are going to cut the muscle, so that is laparoscopic Heller's myotomy. Now, by cutting the muscle, the lower esophageal sphincter will start to relax. And how much do we cut? So we cut 5 centimeters proximal and 2 centimeters distal to the gastroesophageal junction. So from 5 centimeters proximal to 2 centimeters distal, we cut the muscle so that the lower esophageal sphincter starts to relax. Now, the problem with lap Heller's myotomy, or the problem with Heller's myotomy, is that once you've done a myotomy, GERD is very common. GERD is a very common complication which occurs, right? Because now the sphincter is cut, so there is going to be reflux. That is why when we are doing a lap Heller's myotomy, it is usually clubbed. Therefore, we usually club a lap Heller's myotomy with a floppy Nissen's fundoplication. We usually club it with a floppy Nissen's fundoplication so that GERD does not develop in almost all patients, right? So this was regarding laparoscopic Heller's myotomy. Now, one of the latest treatments for achalasia cardia is called POEM, and POEM has also been asked in the exam. What does POEM stand for? POEM stands for per-oral endoscopic myotomy. Per-oral endoscopic myotomy. So POEM is also type of a NOTES procedure. NOTES, I've already told you in the first module, is natural orifice transluminal endoscopic surgery. So it's a type of a NOTES procedure. So what exactly do we do in this? In this, we are not doing laparoscopy. We don't make scars over the abdomen. We'll go endoscopically. So we put an endoscope, we go into the esophagus, then we cut the mucosa. So we cut the mucosa and we create a submucosal tunnel. We create a submucosal tunnel is created. Okay, a submucosal tunnel is created. Then the muscle is cut. The circular muscle is cut. Circular muscle is cut. And then we suture the mucosa. Right? So without any scar over the abdomen, we have carried out a myotomy, and that is known as POEM. So this is a minimally invasive technique. And POEM is generally used for type 1 and type 2 achalasia. POEM is generally used for type 1 and type 2 achalasia. Can also be used for type 3 achalasia who fail on medical management, but predominantly for type 1 and type 2 achalasia. Of course, the complications of POEM also are GERD, because we cannot perform any anti-reflux procedure here and we are cutting the muscle. The patients will land up with gastroesophageal reflux disease. I've already told you that achalasia in the long run can give rise to increased risk of squamous cell carcinoma. There is increased risk of squamous cell carcinoma in patients with achalasia cardia. Now, there are two more motility disorders which I want to discuss. The next one is called distal esophageal spasm. The old name for this, the old name in the old classification was diffuse esophageal spasm. So in the Chicago classification, in the latest Chicago classification, the new name is distal esophageal spasm. And it is 5 times less common than achalasia. It affects females more commonly than males. And there is a motor abnormality in the lower 2/3 of the body of the esophagus. And in this you get repetitive, simultaneous, high amplitude contractions in the body of the esophagus. Now, the clinical features are the patient is going to come with chest pain which is angina-like, so similar to anginal pain, but ECG is normal. There won't be any ECG findings here. So there will be chest pain but no ECG findings. They can have dysphagia and acid reflux is not seen. You don't see any acid reflux in diffuse esophageal spasm or distal esophageal spasm. And if you look at the manometric findings in distal esophageal spasm, so you will see in distal esophageal spasm, the manometric findings are there is normal median IRP, right? So normal median IRP means that the lower esophageal sphincter, therefore lower esophageal sphincter relaxes normally. And the DCI, the distal contractile index, is more than 450. Is more than 450 in patients with distal esophageal spasm. In patients with distal esophageal spasm. Now, patients with distal esophageal spasm, if you carry out a barium, this is very important. If you do a barium in distal esophageal spasm, you will get a corkscrew appearance. This has been asked. You get a corkscrew or a rosary bead appearance. You will get a corkscrew or a rosary bead appearance in this condition. The management of diffuse esophageal spasm or distal esophageal spasm is medical management. Medical management is in the form of calcium channel blockers and nitrates, and usually patients do well on medical management. If they fail on medical management, then we carry out surgery, and the surgery which is done is again a myotomy, as we have discussed for achalasia. Similarly, a myotomy is done for distal esophageal spasm as well. The final motility disorder which I want to talk about is nutcracker esophagus, and you need to know that nutcracker esophagus is the most common motility disorder of the esophagus. This question has been asked in the exam. It is the most common motility disorder of the esophagus. And patients usually come with dysphagia, but they can also come with chest pain as well. And the investigations, we can do manometry in these patients, and the manometric findings which you see in nutcracker esophagus. So these are the old manometric classification, the old Chicago classification, where you get a distal esophageal pressure of more than 180 and the duration of contraction is more than 7 seconds. So more than 180 millimeters of mercury is the pressure and more than 7 seconds is the contraction. Now, according to the latest Chicago classification, there is a variant of nutcracker. And this variant of nutcracker is known as jackhammer esophagus. The new name for jackhammer esophagus is hypercontractile esophagus. So old name was jackhammer, new name is hypercontractile esophagus. And I want you to know here that here the DCI is very high, right? Because there's tremendous pressure which is created inside the esophagus. So the DCI is more than 8,000, and hypercontractility may even involve the lower esophageal sphincter. So you need to know that DCI is very high in patients with nutcracker. The management of nutcracker esophagus is on similar lines as distal esophageal spasm. We try medical management. If medical management fails, we have to carry out a myotomy. So this was regarding the motility disorders of the esophagus, in which achalasia is very important. Before we move on to the MCQs, I want you to know for final year students, very important short notes from this module are, of course, achalasia is a very important short note from this module. You should also know about hiatal hernias. Hiatal hernias have also been asked, and Zenker's diverticulum and Zenker. So these three are super important short notes from this module which you should know. Let's quickly talk about certain MCQs from this module. So this was asked in the INI CET exam. You had a 40-year-old female who comes with progressive dysphagia to both solids and liquids since the last 6 months. So you have dysphagia to both solids and liquids. The BMI is 18.5 without any systemic illness. So low BMI is there. towards the lower side. Barium image is given. So the barium image you can see is gradual tapering. So the barium image is suggestive of achalasia. But there is progressive dysphagia. There's progressive dysphagia. So you are also thinking on the lines of cancer. So to rule out both achalasia and cancer, what will be the investigations which we will do? Correct. Upper GI endoscopy and manometry will help us in ruling out both the conditions. A patient is incidentally detected with a sliding hiatal hernia during a research study. She is asymptomatic but is really concerned about her condition and visits you for advice. Which of the following statements is correct? She should be offered immediate fundoplication. This is false. Why? Because I told you in asymptomatic sliding hiatal hernias, it is very common. You don't need to do surgery in asymptomatic patients. She should be told that if it is a life-threatening condition which can lead to necrosis and of the herniated portion, this is false. This is for rolling. Patient should be reassured about her condition and told that no active surgical intervention is required. This is true, and there is no role of endoscopic biopsy in these patients. Killian's dehiscence we know is a space between thyropharyngeus and cricopharyngeus. This was asked in the FMG exam. And the true diverticulum, this was asked in the NEET exam, is a mid-esophageal or a parabronchial diverticulum. Is a mid-esophageal or a parabronchial diverticulum. Again, an FMG exam question, straightforward question. You have a bird's beak appearance on barium. This is seen in cancer. Another question asked in the FMG exam, this typical barium appearance of corkscrew esophagus. Corkscrew esophagus is seen in patients with distal esophageal spasm. So in which of the following motility disorders normal peristalsis is not seen? So we know normal peristalsis is not seen in achalasia. In achalasia, we don't see any normal peristalsis. Which of the following is true about Chicago classification? Classification based on classic manometry. This is false. I told you it is high resolution manometry. Type 3 is spastic achalasia. This is true. It divides achalasia into 4 types. False. It divides it into 3 types. And DCI measures the pressure of the lower esophageal sphincter. Distal contractile index. No, this is false. It measures the pressure in the body of the esophagus. So this was the question which was asked in the NEET exam. A 35-year-old lady is suspected to have achalasia and is subjected to a high-resolution manometry. On manometry, no normal peristalsis is seen. We know that there is no normal peristalsis. And premature spastic contractions with a DCI of more than 450. So in the question stem itself, they've given the answer, spastic contractions. And we know that type 3 is the one with spastic achalasia. Type 3 is the one with spastic achalasia. So a patient presents with crushing chest pain radiating to the jaw along with dysphagia. Sublingual nitroglycerin provides him relief. He undergoes a manometry which reveals multiple peaked contractions of high amplitude. What is the most likely diagnosis here? Most likely diagnosis, we know this is a distal esophageal spasm. This is a distal esophageal spasm. So the final question in this module, a 35-year-old alcoholic patient develops sudden chest pain after a bout of retching and vomiting. When he presents to the emergency, his pulse rate is 108, BP is 100/70. On auscultation, there is decreased air entry on the left side and a crunching sound. So Hammond's crunch is there. He is diagnosed with Boerhaave syndrome. Which of the following is not a part of the Mackler's triad? Okay. So one point which I want to tell you here is that the art of answering these long stem questions. Now, if the next exam comes in and if you get these long stem questions, sometimes, the question, they write a lot of things, but the question asked is something totally different. So one good way to save time is to read the question, read the last line. What exactly are they trying to ask? And then read the question. Because when you do that, you will get to know what you're dealing with and what are the keywords which you should look out for. So here they've clearly said Boerhaave syndrome, Mackler's triad, which is not seen. So if you know Mackler's triad, you know chest pain is there, retching is there, subcutaneous emphysema is there, fever is not there. So you can answer this question in 10 to 15 seconds and you can save time for other questions. So that was just a tip on how to approach these long-stemmed questions. That brings us to the end of the module on esophagus. It has been covered over 3 parts and it is very important for your exam. Thank you.